This morning it's my pleasure to introduce Dr. Jeffrey Sharon. He's an assistant professor of otolaryngology and a neurologist at UCSF. He serves as the director of the UCSF Balance and Fall Center. Dr. Sharon completed medical school at Mount Sinai and residency at Washington University, followed by a fellowship at Johns Hopkins. So Jeff, thank you very much for taking the time to speak to us today.
Yeah, my pleasure and privilege. Thanks so much for having me. I love these house series, and I frequently listen to them. So it's an honor to be here with a bunch of friends and good colleagues to talk about my favorite topic, which is vestibular migraine. Um, so I've titled the talk Vestibular Migraine 2024. Time for an evidence-based approach. So maybe I'll try to make an argument. Maybe it's time to um, bring the usual level of scientific knowledge and scrutiny that we expect for other diseases over to vestibular migraine, which might be the most common vestibulopathy out there. Um, I have a bit to get through, so I'm gonna dive right in. I do have some disclosures. The only relevant one for this talk is I'll talk about a clinical trial that was an investigator-initiated trial, meaning my idea and I did it all, but it was funded by Eli Lilly. Um, I always like to take a step back and start with a few general thoughts on migraine. Migraine is shockingly common. It affects about 10 to 15% of all people worldwide. The lifetime prevalence for females is about a third. 1 to 4% of the population has chronic migraine, which is a terrible condition. It's the most common cause of disability for those in their working years. So a lot of times we downplay migraine and say, oh, it's just a headache, you have to get over it. But the reality is it's the most common cause of disability worldwide for those in their working years. Um, we're all taught migraine is a headache, and it's not exactly true. When you look across the human lifespan, the earliest migraine manifestation is vertigo. So benign paroxysmal vertigo of childhood is now recognized to be a migraine precursor. So there is clearly a powerful biology between migraine and the inherited brain susceptibilities that make someone have migraine and vertigo. So it's not just a headache disorder, it's a neurological condition with multiple manifestations. Um, Migraine, so as a otologist, neurologist, I think about migraine all the time because migraine seems to be involved behind the scenes with every single disease that I treat. And it's wild to me when you start looking for these associations, how often you find them. So Meniere's disease, a degenerative condition of the inner ear. Well, more than half of patients with Meniere's disease have a history of migraine, way more than you'd expect by chance. Migraines associated with a twofold increased risk of BPPV, another peripheral vestibular condition, and 50% of patients with idiopathic bilateral vestibular loss have a history of migraine. When I look across this, I have to conclude that migraine does something to the inner ear, and figuring that out would seem to be an important key that might open some doors of understanding within neurotology. A few years ago, we tried to put together a schema for understanding how migraine is associated with different vestibular conditions and came up with this. And you could see that it overlaps, and these were just literature published rates with almost every other neurologic condition. In our own cohort at UCSF, we looked at our BPPV patients, so patients who have loose crystals in their inner ear, clearly a peripheral vestibulopathy, and found that those with the migraine history had an earlier age at presentation. And clinically, I do see this as well. So I think this is a real finding. But on average, we're presenting 5 years earlier in life with BPPV when they have a migraine history. So clearly some interaction there. Um, Migraine is also associated with a host of other otologic symptoms. So not just diseases, but the symptoms that we treat. So tinnitus is 3 times more common if you have a history of migraine. Um, Hyperacusis is in the migraine world called phonophobia, but it's a cardinal feature of migraine. Migraine's a risk factor for sudden hearing loss, and oral fullness and otalgia, and I'll circle back around to this, are both common migraine symptoms. When I started out as an assistant professor, it became clear to me that I needed to try to understand migraine to understand any of the symptoms or any of the diseases that I was seeing as an ear specialist. So I think migraine is the proverbial elephant in the room when it comes to neurotology. It's basically involved with every symptom and disease that ear specialists treat. And even when there's a clear diagnosis of some other otologic condition like superior canal dehiscence syndrome, for example, migraine still has a strong influence on disease processes and outcomes. With that preamble, let's turn to vestibular migraine. So vestibular migraine is accepted as a distinct disease that causes dizziness. There was a German study that estimated prevalence at about 1% of the population. And there are diagnostic criteria that were originally proposed by Neuhauser and have been incorporated into the Baronese Society, which is a wonderful international group that has a number of freely available diagnostic criteria for different vestibular conditions on their website. And those are the most widely used consensus criteria for diagnosing vestibular migraine. Um, but this is all new, but it turns out nothing is actually new under the sun. And if you read a quote from Artaeus of Cappadocia 2,000 years ago, you would have to conclude that he's describing the concomitant occurrence of vertigo and headache, probably vestibular migraine. And this patient that he describes also has tinnitus as well, which is a common comorbidity in that with that disease. So here are the criteria from the Baronese Society. And these are important because I will circle back around to them a little bit later in the lecture, because as you can see, there's 2 varieties, vestibular migraine and probable vestibular migraine, but they are envisioning vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. Whether or not vestibular migraine can exist as a chronic condition has been an interest of mine, and I'll try to present some data regarding that in a bit. You need that. You need a current or previous history of migraine with or without aura according to the ICHD. Luckily, the ICHD criteria are also freely available online, so it's an easy reference to check those. And then you need migrainous features with your vestibular episodes. One interesting thing to point out here is that you have to specifically ask patients about photophobia and phonophobia. So if I ask, do you have any symptoms with your vestibular episodes? I get one answer from patients and one answer alone, which is that they experience nausea with those episodes. But then if I want to find out, do they have other symptoms like hearing change or tinnitus change or photophobia or headache, I find that I have to specifically ask those questions. What about my experience in terms of the patients I see and how often do I see vestibular migraine? Well, this was a number of years ago now, and between definite vestibular migraine and probable vestibular migraine, by far that was the most common patient population that I was seeing in running a vestibular clinic. So I thought to myself, well, we have this super common condition, but we don't know almost anything about it. So a number of years ago, I came up with a list of questions. And so this talk is going to be very simple. The talk is these are the questions I was interested in, and you get to hear my attempt to answer each of these questions about this common disease I was treating. Um, as an aside, I had hoped that my clinic was just going to be full of cochlear implant patients and stapes patients and patients with acoustic neuromas and all the fun surgeries we love to do. But it just seemed like my whole clinic was full of vestibular migraine. So I thought, well, maybe it'll be useful to try to study that. Um, Okay, so the first question was, what is the prevalence in the United States? Because we didn't actually know that, and that's an important foundational question to assess the scope of the problem, how big of a problem this is. So we took a representative, nationally representative database, the National Health Interview Survey, or NHIS. We came up with a case definition of vestibular migraine, which we later validated in my clinic, and estimated that vestibular migraine affects almost 3% of the US population, or about 6.1 million people, with a whole variety of secondary effects like missing work, having a fall, visiting physicians, etc. So this is a very, very common problem. In my experience, it's the most common vestibulopathy that I see. Whether or not BPPV is more common is an open question. Interestingly enough, most patients were not told that vestibular migraine was the cause of their dizziness. So underdiagnosis is a real issue with this condition. And migraine and dizziness are statistically incredibly linked together. So no matter how many covariates you control for, the risk if you have a history of migraine headache of having dizziness is incredibly high. Um, and similar to migraine headache, the vast majority of those with vestibular migraine are female. Okay, what about patient attitudes towards vestibular migraine? And this was based on some early clinic observations where patients were having hesitation and mistrust towards the diagnosis. And I put this quote in here years ago, and I still hear it every single week. Without skipping a week, I hear from a patient, "No, you don't understand, doc. I know what my migraines feel like, and this feels different, so this definitely isn't migraine." And then I try to tell my patients, yeah, but you have to put yourself in my shoes. I hear that exact statement every single week. It definitely feels different than a migraine headache. I have no doubt about that, a vestibular migraine attack. But also, when every single patient is has a migraine history and then comes in with these episodic vertigo, I have to conclude that they are related. So there's a number of myths about migraine, right? One of them is that they have to cause headache. And this is a myth, right? We all know that you can have ocular migraines, abdominal migraines, various other types of migraines that you don't actually have to have a headache. You can just have an aura, for instance, without having a headache. So you don't have to have a headache to have a migraine. Another myth is that migraines have to be episodic and they can't be contiguous. But we know that there's unfortunately a far too common entity because it's pretty disabling, chronic migraine, and that's when you have 15 or more migraine days per month, or headache days per month, 8 of which are migraine. Status migrainosus is when you have a migraine lasting longer than 72 hours. So migraines can be episodic. Um, there's a myth that a lot of patients come in, they've seen a lot of other physicians, and they think they have some rare disorder, not a common disorder. And that's a very logical thing to think since you've seen 5 other physicians. But unfortunately, vestibular migraine is very underdiagnosed. I find most of the time, actually, even when you be as thorough as possible and get all the workup, a lot of times patients coming in for vestibular migraine do in fact have vestibular migraine. Um, A lot of patients say to me, no, 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 you don't understand. This thing is ruining my life, and my mom's migraines, she could just, work through it. She could take a nap and get through it, but I can't. So this can't be migraines. So people underestimate how severe migraines are. So with all these misconceptions out there, we wanted to study it a bit more formally. So we did a patient attitude survey and actually found some interesting things. So one of them was that patients, the most common feeling was that they didn't think that we were going to figure out what their cause of their dizziness was. And this is actually correlated with how many providers they see. So patients are wise, and the more providers they see where they don't get a clear answer, the less likely they are to think that we'll provide a clear answer. Um, about a third of patients who met criteria for migraine did not believe that migraine can cause dizziness. So there is a patient education aspect that we need to address as well. So next question, I wanted to do some studies of whether or not treatments work for vestibular migraine, but I was finding that there wasn't a clear way to measure disease severity. So then we embarked on a journey to try to develop an outcome measure for vestibular migraine. And what we ended up with was called VEMPathy, or the Vestibular Migraine Patient Assessment Tool and Handicap Inventory. It intentionally should rhyme with empathy. So we went through a process of developing different items by doing a literature review, expert opinion, and patient feedback. And then we validated it by administering this a questionnaire to 50 subjects with vestibular migraine, 18 control subjects at different time points to assess test-retest reliability, responsiveness, and then there's a number of different tests you run on it. And this is now freely available online. It's a 25-item questionnaire. It can be used to track progress over time. So it is responsive to treatment. And basically, patients are asked a number of different questions, and they have to provide an answer of, is it a problem for them, and then rate it on a Likert scale. What have we found with it? So the Cron box alpha, which is a measure of internal reliability, was good. Test-retest reliability was good. Discriminant validity, meaning the ability of the patient-reported outcome measure to distinguish between those with the condition, so vestibular migraine, and in our case, it was a control group of those with hearing loss, was very high. It is responsive to treatment, and I've seen that in two clinical trials now, and the concurrent validity is good. So it has a high correlation, 0.69, with the dizziness handicap inventory, which is the most widely used metric of dizziness, the most widely used patient-reported outcome measure in dizziness, but it's not the exact same thing. And we do see that across different studies that it's not the same exact measurement. And that's probably because we included more migraine symptoms, whereas the DHI only asks about dizziness. So here's a histogram showing a distribution that approximates a normal distribution of empathy scores. So at my center, the mean score is about 45. Here is showing discriminant validity. So you can see scores are very different across cases and controls. And here is a scatter plot of the dizziness handicap inventory and the empathy scores. So you can see a pretty nice correlation, but it's not a straight line. They're not the exact same thing, but they are measuring, I think, similar constructs, as you'd expect. We then did an exploratory factor analysis where you take your 25 items and then you use mathematical methods to then find latent groupings within the answer choices and how people respond to the different items. So the groupings that naturally sorted out due to these mathematical methods were kind of interesting to me because the way things grouped in some ways made sense. So, for instance, I've always wondered what lightheadedness means when someone comes in with lightheadedness, but they're not passing out, but it's a common thing that patients say, and I didn't know what it means, but it actually clustered together with stress and anxiety. So now I think that lightheadedness is just another manifestation of stress or anxiety. And interestingly, ear pressure clustered together with head pressure and headaches. So now I think of all those things as probably equivalent. So like an ear headache in the setting of vestibular migraine. And you could see here a lot of the other clusterings seem to make sense as well. So this is a recent study with one of my prior research coordinators, Adam Gardy, where we tried to figure out what's the minimal clinically important difference for empathy. We used an anchor-based method. So basically patients were compared their change in empathy score before and after some intervention, and we pooled together a lot of patients, so there are a lot of different interventions, and compared that change to a change on a Likert scale, single question, which was global impression of change. And you could see at the bottom there that as the global impression went from a 0, which was worse, which thankfully no one had, to number 6, which was very much better, the empathy score difference before and after the intervention nicely increases. So this is a good validation that if your empathy score increases by 20, then you were likely to say that you're feeling very much better. And so using this, the MCID was calculated at 6, but you could see if I was running a study using empathy, I'd probably use a cutoff around 9 or 10 just to make sure that people were definitely improving with that. Here's another recent publication we looked at. So well, I'll talk about some clinical trials we've done. For the clinical trials, I always have a baseline period. So before an intervention, we're just kind of measuring disease severity. And in this one, we were texting people every single day for a month and saying, uh, tell us about, for the last 24 hours, how's your dizziness? Was it no dizziness? Mild dizziness, which is a 1, moderate dizziness, which is a 2, or severe dizziness, which is a 3. And as the dizziness gets more severe, the color red gets more dark. And what you could see here is this is a month, and this is 66 subjects with vestibular migraine, giving us data for a whole month. So it's a peek into the average month of someone with vestibular migraine who is signing up for clinical trials. So probably a more severe phenotype than the average person. But what you can see is the whole thing's red. So most of these patients are actually having some degree of symptoms every day. And the more severe ones at the right side of the screen here are having severe symptoms almost every single day. But it's very rare for someone to not have any symptoms. So I think we are underestimating how severe this disease is for a lot of our patients, at least I was. Okay, what about impact on quality of life? So here is a cohort of subjects with vestibular migraine, about 50, and here is the SF-36, which is a widely used metric of quality of life, and you can see there's 8 different domains that are measured, and here are your mean scores. 100 is perfect health, and 0 is a complete disability. And you can see here that the scores are actually not great, indicating that this disease does significantly affect quality of life. And you can see that these quality of life scores are pretty well correlated for the most part with empathy scores. Um, there's normative data for this, but there's also a publication showing data on different SF-36 subdomain scores when you have bilateral vestibular loss. And it interested me because I think of bilateral vestibular loss as a very disabling condition where patients are falling, there's oscillopsia, it's a chronic condition. But actually, those with vestibular migraine on most metrics were scoring worse than those with bilateral vestibular loss. So clearly, this disease, not a shock to anyone, I'm sure, who sees these patients, and certainly not a shock to anyone who has this terrible disease, but it does significantly impact quality of life. What about secondary impacts? So missing work, risk of falls, impaired cognition. So we looked at this as well. This was another nationally representative data set with 30,000 participants. It was a 2016 NHIS data set, and again, using that same validated definition of vestibular migraine. So we found that self-reported cognitive dysfunction is way higher in those with vestibular migraine than control subjects. So about uh, 40% saying some difficulty thinking or remembering with vestibular migraine compared to 12% of controls, meaning those without vestibular migraine or migraine, and a lot of difficulty in 11%. And interestingly, this was higher for vestibular migraine than migraine headache. So we had a group of migraine headache, and the self-reported cognitive dysfunction was worse with those with vestibular migraine. And we're currently doing a study to try to understand this phenomenon a bit better. We also found that having increased falls and decreased mobility, this is all self-reported data, but a huge data set, was higher when you have vestibular migraine. And when you had vestibular migraine and cognitive dysfunction together, then you really had a very high odds ratio of having a fall, 5 times higher than the average population, and of having a issue with mobility. In addition, work absenteeism is common with vestibular migraine. And again, we were seeing that it's even worse when you had this confluence of vestibular migraine and cognitive dysfunction, missing on average 13 days a year uh, due to these symptoms, due to this disease. Okay, so we're moving right along into our next question. So we're slightly more than halfway through with our questions. Our next question is, are the current diagnostic criteria adequate? So I alluded to this at the beginning with the Baronnet Society criteria, and I don't want to dig on them. I love the Baronnet Society. And I think it's a wonderful group, and I think they've made incredible efforts to diagnose and provide diagnostic criteria for all sorts of vestibular conditions. But I think we do have an obligation to question the criteria and say, are they perfect or and do they adequately reflect what patients are going through? So in the current criteria, the episodes last 5 minutes to 72 hours, meaning it's an episodic disorder. But when you start looking at migraine headaches, you see chronic variants. And my clinical experience, and I showed you that month in the life of a vestibular migraine patient, a lot of them seem to have chronic symptoms. So we conducted a prospective study of vestibular migraine phenotypes, and there's a PubMed ID for that. So this is 54 prospectively enrolled subjects, all met Baronnet Society criteria for vestibular migraine or probable vestibular migraine, except we didn't use time course to exclude anyone. So your episodes could be any length. And we asked about a whole bunch of interesting things that I'll show you. So we found that a prior migraine history is present in 80%. So now I ask all my patients, anyone else in the family with a history of migraines, it's a very predictive question. And we found that 44% report that their vestibular symptoms are continuous, not episodic. And there's something that makes sense about this. I find that these patients frequently have episodic symptoms and chronic symptoms. But if you think about sensory sensitivity as part of migraine, right? They have light sensitivity, they have sound sensitivity, they also have vestibular sensitivity. What does that mean? That means levels of movement that don't bother other people will bother them. So when they turn their head quickly, or get up quickly, or have some other body movement, they get dizzy from that. And that degree of symptomatology makes sense that it would lead more towards a chronic phenotype. History of motion sickness also incredibly common here. So here's what happens when you ask them what's the most common duration for your dizziness episodes, and you could see here, yes, half of them are fitting into this 5 minute to 72 hour window, but about 40% are having longer episodes. And interestingly, some patients have shorter episodes. Um, so I'm not sure that the timing really matters. People think I'm being glib when they say, how long can a vestibular migraine episode last for? And I say, well, anywhere from seconds to years. But I actually do believe that. Here's your dizziness frequency per month, and you could see, at least in my cohort, most patients are having more than 15 dizzy days per month. Begging the question, maybe we should have a chronic variety of vestibular migraine. Here's the triggers, and I found this very illuminating. So motion's the most common trigger, but stress is actually the second most common self-reported trigger for for vestibular migraine. So it may be stress is a good treatment target as well. And I'll talk about a trial we did to try to address stress as an important trigger and covariate because anxiety is frequently present as well. Bright lights, busy visual scenes, scrolling on a screen. So a lot of the classic migraine triggers are actually vestibular migraine triggers as well. And associated symptoms during dizziness, you can see that light sensitivity, sound sensitivity are incredibly common, but so is ear pressure. So whenever someone comes in with ear pressure, I always check for migraine and vestibular migraine. Okay, so what are we proposing? We're proposing that similar to migraine headache, we should divide vestibular migraine into episodic and chronic forms and have diagnostic criteria for each. So that's our proposal. Um, okay, are there effective non-pharmacologic treatments for vestibular migraine? So let's get into that. This was I'm at UCSF, so this was a very San Francisco study to do. So we have a Osher Center for Integrative Medicine, which is a wonderful place that used to be across the street from the office where I was seeing patients. And they were offering a variety of holistic complementary medicine treatments for a whole variety of conditions. And one of them is mindfulness-based stress reduction, abbreviated as MBSR. And it is now an accepted and proven medical treatment for depression, for anxiety, for chronic symptoms. People have looked at it for tinnitus and other otolaryngologic diseases. And we thought maybe it makes sense to study it for vestibular migraine. Why? Well, number one, the same way I was talking about sensory sensitivity in migraine. So a lot of patients have sound sensitivity, light sensitivity. They also have medication sensitivity. I think that's another form of sensory sensitivity. So the side effects from medications are incredibly common. And that is an issue in a disease that's predominantly treated with medications. It's a bit of a paradox there. So we were trying to find non-pharmacologic treatments. I didn't show this data, but the rate of comorbid anxiety in the vestibular migraine population is about 50%. And we don't understand why, but that's something that needs further study, but it's there and it's a reality. And stress was our number two trigger for vestibular migraine. And MBSR is a proven treatment for anxiety. And as you can tell from the title, it's actually designed around stress reduction. The pathophysiology of vestibular migraine, which isn't fully worked out, seems to involve sensory sensitivity, hypervigilance, meaning paying a lot of attention to bodily symptoms, catastrophizing, meaning when you have a symptom, worrying about it and worrying that it's never going to go away and thereby magnifying the symptom, and functional maladaptation, meaning trying to adapt to a symptom, but then actually having a maladaptation because that short-term adaptation is not helpful in the long term. And all of those things may be helped by MBSR. So with that in mind, we attempted to study mindfulness-based stress reduction. So at the Osher Center at UCSF, you get 8 weekly sections with an instructor. You have to read this book called Full Catastrophe Living by John Kabat-Zinn. And then we covered their fees, and then they try to change your perspective so you experience the world in a very non-judgmental manner. So it's a bit of a perspective shift to try to take yourself out of your body in a sense and experience the world in a non-judgmental manner. So this was a single-arm, open-label prospective trial funded by a core grant obtained by Dr. Eric Formeister, and it's going to be published any day now, he promises me. So here's your demographic information. As you could see, very high rates of anxiety and depression in this population, which is common for vestibular migraine. So here's your DHI score, dizziness handicap inventory, before and after intervention. So a nice reduction there. Here's your Vempathy score before and after intervention. So as you can see, a nice reduction there. So this treatment, at least in this single arm study, seems to work well. And this is interesting. So this is that text message where we have the mean dizziness score for the whole group over time. So remember, 3 was the worst, 0 was no dizziness. And you could see there that during the baseline period, it's just randomness. But as the study starts, the average score over time starts going down. And this was maybe the most interesting graph of the study. So this is the different text message responses you could have: severe dizziness, moderate dizziness, mild dizziness, or none, over the course of the study, and the count of how many subjects were giving us those responses. And what was interesting to me is you could see that the moderate curves and the mild curves basically are mirror images of each other. So I took this to mean that MBSR works by changing moderate dizzy days into mild dizzy days. And maybe that makes sense in terms of the tools that it provides to rethink about and have a different perspective about your symptoms, which actually changes them in terms of how you experience them over time. Okay, moving right along here, are there effective medications for vestibular migraine? We did a clinical trial of a medication that blocks a brain chemical called CGRP. So what is CGRP? So CGRP, calcitonin gene-related peptide, is a neuropeptide, and it's found throughout the peripheral and central nervous system. It seems to be integral to how a migraine happens, because part of migraine pathology is the trigeminal-vascular system, and it's expressed and released by the trigeminal-vascular system. But as you can see from this nice histologic image, it's also, and this is from Anne Lubke's lab in Rochester, it's also expressed in the vestibular periphery, interestingly enough. It's related to migraine. So CGRP infusion causes migraine. And interestingly enough, I tried to look at whether or not we could do CGRP infusion studies to cause vestibular migraine. And that is a regulatory nightmare and not actually feasible to do that study in the US, is what I learned. And then CGRP blockade is a proven treatment for migraine headache. So now there's a number of different medications, monoclonal antibodies, and also small molecules called GPANs that have been shown in numerous clinical trials to prevent or reduce migraine headaches. Interestingly enough, though, the story doesn't end there. CGRP knockout mice have lower VOR gain and balance difficulty. And this is, again, work done by Dr. Lubke. So there's something going on here with CGRP and vestibular function. And we're actually putting together a review paper to look into that in a bit more detail and a bit more systematically. So here you can see 2 of Dr. Lubke's studies where VOR gain and also balance are impaired in these CGRP knockout mice. So clearly there's something going on with CGRP and vestibular function, in addition to the fact that CGRP is related to migraine headache. So it made sense to us, also based on some early anecdotal data, to take these new migraine treatments blocking CGRP and do a study. So we called it the investment study, or investigating vestibular migraine Emgality treatment. Emgality's the trade name for galcanezumab, the chemical name. And the drug, and this is the drug produced by Eli Lilly. So they provided us money to do an investigator-initiated study. There's the the clinicaltrials.gov registration. So we had a 1 month baseline period and a 3 months of treatment with a 1-to-1 randomization of drug to placebo, stratified by sex, and vestibular migraine versus probable. The outcome measures, we did the change in empathy score. Since we went through all that work of developing a patient-reported outcome measure, we figured we'd use it as an outcome measure for our study. We also looked at the number of definitive dizzy days. So this is on that text message system. Any day with a moderate or a severe dizziness was counted as a DDD, or definitive dizzy days. This is similar to in migraine headache studies, looking at migraine headache days, and also changes in the dizziness handicap inventory and the global impression of change. And we talked about Vempathy already, freely available on the UCSF Balance and Fall Center website. Link will be provided at the end of the talk. So here's the study calendar. You enroll, you randomize, and then you went to either a placebo group or the galcanezumab group. And you did 3 months of treatment. The inclusion criteria are what you'd expect for this. So basically, we use the Baronese Society criteria for diagnosis, and there were some minimum severity. So you had to have 4 DDDs in the baseline period and a minimum Vempathy score. The baseline characteristics were pretty evenly divided between the 2 groups. And so here's the results. So the change in Vempathy when you got galcanezumab was a drop of 15 points. And the change with the placebo group was a drop of 5.1 points. And so a pretty big market difference here in terms of the improvement in score that you got with getting the drug as opposed to the placebo. The DDD count by month. So this is starting out. The average person in this study had 18 DDDs in their baseline month, so pretty severe phenotype. And you could see that placebo actually works okay. So by the 3rd month, they're down to 12.5 days per month of having these DDDs. But the galcanezumab group is having 6.6 days per month. So basically doing much better and having a double the reduction in DDD days as a result of the treatment. So really nice separation, especially in month 2 and 3. And then here you could see that in a different form is basically your reduction from baseline from 18 days to your month 3 was double in those getting the active drug as opposed to placebo. The dizziness handicap inventory, actually, if I had known this, I would have picked this as the primary outcome measure, had one of the biggest changes, so a drop of 22 points in those getting galcanezumab and only 8.3 in those getting placebo. And this was just the global impression of change. So a single question, how did you feel the drug you got during the treatment helped you? And 70% or so, this is probably the take-home message of those getting galcanezumab, thought it was moderate or better. I will say cures are pretty rare, but it's clearly very helpful. And 23% responding to a placebo. So what's the summary? The summary is those who were randomized to galcanezumab as opposed to placebo had far fewer definitive dizzy days, better reduction in dizziness handicap inventory and Vempathy scores, and better performance on basically every single metric, even those that did not reach statistical significance. Okay. I'm about to wrap up because I was told to talk for 45 minutes, but just a final few slides and some closing thoughts. So what's the pathophysiology? For a textbook chapter, Christine Graylap, who's an artist at Stanford, put together this nice a schema for us looking at potential sites where vestibular migraine could be causing symptoms. And the reality is there's a lot of different potential sites of disease and pathophysiologic issues. And we don't fully understand this disease. I think based on my results, I would say CGRP is likely a part of pathophysiology, at least for a lot of patients, but probably not everyone, which is why not everyone responds to the drugs. So to investigate this further, we're about to wrap up enrollment on a fMRI study, so I don't have any results to share with you. So this is more of a stay tuned thing where we've connected with Dr. Jason Allen now in Indiana and Dr. Rusty Gore connected to Emory to look at some fMRI data in vestibular migraine. So stay tuned for some information. So just a couple final clinical pearls for the clinicians out there and the learners out there. I'll stand on my soapbox for 1 second and just go through these. So differential diagnosis. Every single person with dizziness and vertigo should include vestibular migraine on their differential diagnosis. It is incredibly common. And what does that mean? That means you should ask them the vestibular migraine question. So you should ask everyone about migraine history. You should be familiar with how to diagnose a migraine headache with or without aura. And you should ask about associated symptoms like photophobia and phonophobia and triggers like the ones we showed in that in the bar chart before. Vestibular migraine is not a wastebasket diagnosis. So it's a specific disease, and we should be thinking about it as a specific disease with a specific pathophysiology, not just as a place to place patients so that we don't know what to do with them. Vestibular migraine is highly treatable, and some of my most rewarding patient experiences is with vestibular migraine patients. They're also, incidentally, a wonderful group to do research with because a lot of them seem to understand that there's not enough knowledge and not enough people studying the disease. So when I say, oh, do you want to sign up for a study where you might get a placebo, or do you want to go sit in an MRI for 2 hours while we try to cause vertigo while you're in the MRI, a shocking number of them say yes. So it really is a wonderful patient population that's been really great for me to work with. But a lot of them do improve with treatment. Sadly, not all of them, but I find that this could be a very rewarding area of medicine. You do need a multidisciplinary approach, as you'd expect. I find that vestibular migraine is right in the cracks between ENT and neurology, and that is an issue for patients, and we have to do better for them. If you're an ENT doctor treating these patients, I actually think that it's up to you if you want to treat them or refer them to neurology. But the line I will draw in the sand is I think everyone who sees dizzy patients has to be able to at least diagnose vestibular migraine. White matter abnormalities are super common on brain MRIs. So a lot of times we have to reassure patients because the language that radiologists use can be alarming regarding those findings. I find that it's still a trial and error approach in 2014. So we do need to follow up on patients and see how they're doing. And I've come up with a model where I split that responsibility with an excellent APP, because otherwise it's impossible to run a surgical practice and also see these patients. But I actually think both are really impossible. Another elephant in the room is anxiety. It's a frequent comorbidity. I don't think the anxiety is what causes their symptoms. I think it's a comorbid condition, but I don't think we can ignore it either. I think as part of a holistic treatment plan, we have to address that. And finally, there's likely, similar to migraine headache, episodic and chronic forms of vestibular migraine. And I did my fellowship at Hopkins, so the last one is don't miss superior canal dehiscence syndrome, the great masquerader, according to Dr. John Carey. A lot of the symptoms overlap, so that is one thing that I think about when someone comes in with vestibular migraine because it's treated entirely differently. Final summary slide, I swear, and then I'll stop. VM may be the most common cause of dizziness in the world. We now have a validated way to measure disease severity. The current care model, we have to acknowledge, is inefficient and frustrating for patients. We need more clinical trials. I didn't get into this, but there's clinical trials that triptans and beta blockers don't actually work for vestibular migraine. So we need to specifically study every migraine drug to figure out if it works for vestibular migraine. But CGRP, as I've indicated, is likely a good treatment target for vestibular migraine. These are all my students and collaborators and everyone who's helped with all this work. This is the funding I've gotten to be able to do some of this stuff. And then this is our website where we do have the Vempathy online. And I like to draw, so this is my mastoid. And with that, I will stop and be happy to take any questions.